Welcome everybody joining us online for this public lecture on global health security, a blueprint for the future. This is part of our current public lecture series, Polycrisis, which is exploring the multiple overlapping crises of our time and considering how we can navigate the global polycrisis. Today, we are delighted and privileged to have Professor Lawrence Gostin joining us to give us his thoughts on the need for a pragmatic plan for the future of global health security. Professor Lawrence Gostin specializes in public health law and is currently a professor at Georgetown Law, professor of medicine at Georgetown University, and professor of public health at Johns Hopkins University. He's the founding O'Neill Professor of Global Health Law, faculty director of the O'Neill Institute for National and Global Health Law, and director of the World Health Organization Collaborating Center on Public Health Law and Human Rights. He's part of the WHO's International Health Regulations Group of experts and the WHO Expert Advisory Panel on Mental Health, as well as numerous other WHO expert advisory committees, including on the pandemic influenza preparedness framework, smallpox, and genomic sequencing data. Professor Gostin co-chairs the Lancet Commission on Global Health Law and serves as a member of the independent panel for a global public health convention in response to the COVID-19 pandemic. He is renowned for being the author of the Model State Emergency Health Powers Act, as well as being a prolific publisher in the top journals in medicine and law, and holding editorial appointments in leading journals, including being the Law and Global Health Editor for the Journal of the American Medical Association. He's also a member of the National Academy of Medicine and serves on its Global Health Board. And in 2016, he was appointed by US President Barack Obama to a 6-year term on the President's National Cancer Advisory Board to advise the nation on cancer prevention, research, and policy. Professor Gostin has been awarded 4 honorary degrees and also received distinguished service awards from, amongst others, the National Academy of Sciences, the American Public Health Association, and the Royal Society of Public Health. Here in the UK, he received the Rosemary Delbridge Memorial Award for the person who has most influenced Parliament and government to act for the welfare of society. Professor Gostin has spent 3 decades designing resilient health systems and governance frameworks that take account of our interconnected world. As a close advisor to the Centers for Disease Control and Prevention, the WHO, and many other public agencies globally, as I've just noted. Professor Gostin has been at the center of public policy and law through multiple epidemics, from AIDS and SARS to Ebola, MERS, and Zika. He currently works closely with the Biden administration and global institutions like the WHO and the World Bank on the COVID-19 response. This evening, Professor Gostin will talk for about 20 minutes or so, and then I'm going to ask him some questions before we open up the floor to questions from participants, which you can send in via the Q&A function on Zoom. So without further ado, I'm now going to hand over to Professor Gostin. The floor is yours. Thank you very much.
Okay, well, thank you very much, Matt. It's a very, very kind introduction. And I'm going to try to be as brief as I can, not only because I want to get to question and answer, but also just sheer exhaustion, because I've been going back and forth to Geneva to work on the pandemic treaty and the international health regulations. So what I thought I would do is, rather than discuss my book, which is, Global Health Security, a Blueprint for Reform, which you can see behind me. It's a Harvard University Press book that really looked at a whole range of, key blueprints for how we can make for a safer, fairer world. But instead of that, I thought what I would do is first go retrospectively and talk about what happened during COVID-19, but particularly focusing on the human rights violations. I just had an article in the Lancet with a group of international authors that systematically examined the human rights implications of the COVID-19 pandemic. And if I get the chance, I'll try to put that link in the chat. But if not, maybe Matt or Laura could just look it up and put it in the chat for me. And then I'll move on to really what I consider 2 historical and transformational events going on in Geneva for global health governance. the pandemic instrument, or what's commonly called the pandemic treaty, which I've been closely involved with, and the revision of the international health regulations, which is the governing instrument for global health security, and has been since WHO adopted its predecessor, the International Sanitary Regulations, at its formation in 1948. And the last time that the international health regulations were substantially reformed was after the SARS epidemic. I have to be somewhat circumspect on what I say because I'm a member of the WHO International Health Regulations Review Committee, and so we're currently writing our report, and so I can't talk too much in depth about that. But let me start with a retrospective. We're about to approach the 3rd-year anniversary of the COVID-19 pandemic, and it's a moment to reflect on untold human suffering. It's not just the millions of lives lost, and the trillions of dollars in economic productivity lost, but also I think we need to reflect on the vast deprivations of freedom, the noxious discrimination, and the erosion of democratic ideals that we've seen coincident with the COVID pandemic. And as I said, my colleagues and I discussed this at quite length in a recent Lancet article. The human rights violations have been broad in scope, and they began with the origins of COVID-19 in Wuhan to China's current dynamic zero COVID strategy. In Wuhan, of course, China was very late in notifying WHO. In fact, if you look at the timeline, China never really did notify WHO. WHO found out through unofficial sources, and China then confirmed it, but confirmed it late as well. It did share genomic sequencing data, but also late. Then, of course, there were the whole controversy over the origins of SARS-CoV-2. I think most of us believe that it was a naturally occurring zoonosis, but nonetheless, China has not allowed a full independent WHO team to go and look at the bat caves in southern China, the Wuhan market, and the Hunan Institute of Virology. And certainly its current dynamic zero COVID strategy has long been enforced through, deep intrusive surveillance and coercive restrictions. But governments have abused their emergency powers quite extensively to delay elections. They've abused COVID-19 mandates to detain and arrest marginalized populations like migrant workers in India and returning refugees in Venezuela. So I think, essentially, there are two major issues. One is the civil and political rights that have been violated, but also in the deep vaccine apartheid and other inequities that we've seen, where the United States, Europe, and high-income countries were nicely vaccinated, but so many were left behind in Africa and other low and income countries. And on civil and political rights, it wasn't just China that threatened to jail truth tellers. Authorities in countries like Egypt, Russia, Venezuela, Madagascar, and Bangladesh did as well. So let me start with civil and political rights. Disfavored and marginalized populations fell victim to arbitrary arrests. Venezuela targeted refugees for COVID-19 quarantines. Quarantine facilities amounted to cruel and inhuman treatment with unsanitary conditions insufficient food, water, and medical care. It was similar in Burundi, and in India, police disproportionately detained and arrested marginalized populations for violating COVID-19 mandates, including migrant workers and slum dwellers. Governments also undermined democratic institutions as they abused emergency powers. Hungary's prime minister used emergency powers to direct funding away from opposition strongholds, while El Salvador, as president, ignored a Supreme Court's order to stop arresting people for stay-at-home orders, and he suspended parliament. Governments and leaders in countries from Russia, Ethiopia, Malaysia, Zambia, and Greece used COVID-19 and related regulations to delay elections, cling on to power, and restrict political protests. Some of the worst aspects of COVID-19 are all too familiar to us, which are the deep inequities. We saw this certainly within countries. One US statistic tells a global story of COVID-19's harshest impact on marginalized populations. The overall US life expectancy for Americans fell 2.7 years during 2020 and 2021, but it plummeted to 6.6 years for Native Americans, leaving life expectancy at 65, which is a level that had not been seen in the overall US population since 1944. This was true with indigenous populations in Brazil, Somalis in Norway, and in Sweden, Black and other ethnic minorities in the United Kingdom, Asian migrant workers in Saudi Arabia, and migrant workers in Singapore, all were among the groups who suffered outsized impacts. I think we remember the early days of COVID-19 for the unequal distribution and the scramble for diagnostic testing kits, personal protective equipment, and vaccine and ventilators. But the global outrage, I think, peaked with vaccine apartheid. For example, in June 2021, 1/3 of the people in high-income countries, including the UK and the US, were vaccinated, but only 0.2% in low-income countries. COVAX, the vaccine arm of the ACT Accelerator at WHO and Gavi, were severely underfunded. And today, the inequities manifest through unequal access to antiviral treatments like Paxlovid. Beyond that, the COVID-19 pandemic has had effects in a whole range of different spheres, linked to climate change, also linked to the Ukraine war. It thrust tens of millions of people into extreme poverty, more than 200 million people in acute hunger, more than 460 million children could not access education or remote learning, and particularly in sub-Saharan Africa. At their core, I think human rights are about human dignity, and the plethora of human rights violations have done a service to equal human dignity. And it's for now, as we approach the 3rd anniversary, to honor the lives and to reinforce human rights and reassert the idea of equal human dignity. Now, we have two possible ways to do that at Geneva, which both are transformational. And I think we're now experiencing a moment in the world which has not been seen since 1948, and when WHO was formed with the WHO Constitution, the Universal Declaration of Human Rights. So now we have to look at how we can actually transform the world to make it a little bit safer and a little bit fairer. There are two processes going on in Geneva. One is a pandemic instrument, which will be under Article 19 of the WHO Constitution. The only other treaty that has been negotiated under Article 19 is the Framework Convention on Tobacco Control. The intergovernmental negotiating body has put out what they call as conceptual zero draft, which included a lot on equity and also on security. But it's only a conceptual zero draft. We don't even have the zero draft now. Today and tomorrow in Geneva, the Intergovernmental Negotiating Body, the INB, is meeting and reviewing this dynamic zero draft. Within the next hour or so, the O'Neill Institute, which I direct, is going to put out a briefing on that subject, which you'll be able to find on our website. The second big issue, of course, is the international health regulations. The IHR have 196 states parties, so it's one of the, if not the most widely adopted treaties in the world. And it's something that really is essential because we don't know what's going to happen with the pandemic instrument. But we do know that there will be an IHR and it will probably be revised. In Geneva, my review committee, the review committee that I sit on, is looking at over 300 different proposed amendments by governments around the world, and will be issuing a report in the new year, and a working group on the IHR is going to negotiate the new instrument. Both the pandemic instrument or the pandemic treaty and the IHR revisions are due to be adopted by the World Health Assembly in May 2024. And I think I want to just finish with two things. I mean, one of the things I've noticed in all of my work in Geneva is that there is an enormous north-south divide on both of these instruments. The North really wants better security, better information sharing, scientific sharing, pathogen sharing, genomic sequencing data, and rapid reporting of outbreaks to make the world more secure. They also want, better evaluation of domestic health systems to ensure that they have core health system capacities. The South, on the other hand, is focused mostly on equity, and they want an equity mechanism to be able to really not go through the kind of ordeal that they went through during the COVID-19 pandemic. The problem is that the North wants one thing, the South wants the other, and they're transactional, and nobody will give in to the other. And in my view, and what I've told member states repeatedly is that after everything we've suffered during COVID-19, failure is not an option, and that we need both. We need a world that's safer and more secure, and we know how to do that. And we need a world that's fairer and more equitable, and we know how to do that. And we should try to be as robust in both realms as we possibly can. As I've mentioned repeatedly, in my view, this is a pivotal moment for global health governance. And we can either revert to complacency, which is what I say in my global health security book, or we can be bold and really try to aim for something that we can be proud of, and we can, so our children and our grandchildren can inherit a world that makes them safer from pandemics and also makes it fairer and more just for everyone around the world. So with that, thank you very much for listening to me. I'll stop now and be happy to have a conversation.
Well, thank you, Professor Gostin. That was, a real interesting talk through some of the work you've been doing and some of the things that are coming up with the WHO, and really thinking about these trade-offs that we've seen around the globe in terms of what the North and the South are looking for. And as you say, this has been a kind of, it's been so different, the COVID-19, the fact that it was a global pandemic. So maybe I'd just like to kick off with asking you, you've been involved in previous experience with dealing with epidemics, dealing with academics and epidemics, but dealing with epidemics like SARS, Ebola, Zika, which obviously informed to some extent your response to the COVID-19 pandemic. But what what has made this so different and brought us to this pivotal point that you talk about? What's been so different about the COVID-19 pandemic compared with the other? We've had large epidemics before, but is it just the kind of truly global nature of this that has brought us to this kind of pivotal point?
Yeah, thanks, Matt. I mean, I think, yes, it's partly the fact that this was such a global event. Of course, H1N1 was also a very global event, but we didn't see the mass deaths that we saw during COVID-19. I think SARS could have been a potential for the same kind of response, but we were able to get SARS under control, and within a number of months. Zika and MERS really tended to be confined to certain countries. And overall, I think, things like Ebola, rich countries, the UK, European Union, the US, was never really threatened by it the way that COVID devastated our countries. And countries in the West, performed really, really badly and were suffered badly. In my mind, really, the only precedent that I can think of that comes even close to this, and I'm not talking about the great influenza pandemic of 1918, but the one that that I've experienced is the AIDS pandemic. But even that tended to be more among marginalized communities and didn't affect large swaths of the population in the North the way COVID has. Having said that, the AIDS pandemic has killed many, many more people. It's been pervasive for much, much longer a period. We just had World AIDS Day, and it continues to rage. It baffles me why we still have any children in the world that are born with HIV, but that's the case. And it also baffles me why we don't get everybody on antiviral treatment and bring the AIDS pandemic down to near zero. But I think COVID has been unique in so many ways. And as I say, the only parallel that I can think of is AIDS, and it's not a perfect parallel.
And I think it's that uniqueness, I suppose, of the fact that it was a global pandemic. It was something that was not just affecting marginalized communities, but was affecting and transmitting much more broadly, that has led to such devastation. Because I think the UK was supposedly well prepared in previous reports, I think in 2016, saying we're well prepared for kind of a global pandemic. Yeah. And obviously that proved not to be the case. Mm-hmm. Yeah. So what went wrong? I think obviously the US as well, similarly kind of a lot of resource for preparation, but what went wrong there?
Yeah, I was actually a member of the board that wrote the Global Health Security Index, the one that you're referring to, Matt. We did that with The Economist and Johns Hopkins and others, and actually we finalized our report in London. And you're right, the U.S. was ranked first in global health preparedness. The UK was second, and we ended up being the two worst performers. Where we then revised the Global Health Security Index, and we're revising it again. We hope to meet in London again at The Economist to try to kind of update it. But I think the broad view of our committee was that we didn't take account of political leadership and the politics of it. And,
Mm.
you had Boris Johnson, we had Donald Trump, and that was pretty much a disaster. But even under Obama, I work really, really closely with the White House, and there's some fantastic people on the COVID response. We've still, suffered badly, and with kind of anti-science sentiment, disinformation campaigns, relatively low vaccination rates. I think a lot of it had to do with political leadership. Some of it just had to do, I have to say, with how what I call SARS-CoV-2 is the most wily virus I've ever seen. It's just like a piece of jelly. You just can't get your hand on it. And even countries that did really, really well, like Australia and New Zealand, and even Japan and Taiwan ended up having surges, and China, which has been able to put it off with its dynamic zero COVID strategy, is now suffering the consequences. It's the most infectious pathogen on the planet, and we really, the only bright spot was that we really did very, very well with vaccines, but we didn't get enough global uptake of those vaccines, and we're still relatively low. The U.S. is extraordinarily low compared to many of its partners, including the UK.
Yeah, it's interesting. You mentioned the kind of political leadership and also the politicization of the pandemic, because this was something that was it may have been more accelerated in the US. I think in the UK, it was a case of initially very much a kind of everyone pulling together, all in this together, but it quite quickly divided along party lines in terms of partisanship, and in terms of whether the government was doing the right thing or not. And then
in the United States, the death rate among Republicans is far higher than among Democrats. There's no reason for that.
Yeah, and I suppose it comes to the way in which information is used and the way in which information is shared, and I think there's certainly a slight kind of revisionist strand in some commentary now around lockdowns in the UK, that looking back, people now trying to suggest that lockdown was unnecessary or wrong and caused more problems. And again, this is quite politicized. So I suppose this is something, thinking back to that kind of preparedness, that it's very difficult to forecast the way that, as you say, the kind of actual political leadership in the form of Trump and in the form of Boris Johnson, the decisions that were made, but also the way in which this became very highly politicized, and how that then affected people's behavior, and like you say, with leading to a higher rate of death amongst Republicans, which is related to, I guess, to how they consume that information and what they believe to be true and not.
Yeah, science has taken a huge hit from COVID-19. It really has. It isn't all everyone else's fault. Scientists have not been good health communicators, and they didn't. Health officials weren't clear enough with the public to say, this is what we know, this is what we don't know, and this is what we're trying to do to find out what we don't know, and that we've got a lot of scientific uncertainty that we're trying to figure out. Instead, many scientists really kind of put out, including the CDC, Public Health England, WHO, things on, miscommunications on masks, miscommunications on aerosolized spread of SARS-CoV-2, and confusing information about quarantines and lockdowns that could have been better conveyed. The truth is that lockdowns, I think, in a temporary measure, were necessary to prevent our hospitals and health systems from being overwhelmed. But if you were going to have a lockdown, you needed to have a plan when the lockdown was over,
Yeah.
and neither of our countries had a plan. We just kept locking down and opening up and doing the same thing over again. As I say, a lot of this was the virus, but also a lot of it was just really bad handling of the pandemic.
And I think probably now, we live in a world where there are vaccines that we know are effective and seem to be continuing to be effective against, mutated strands and variants, which is very different to how it was, initially. I think that's a game changer, as we know, having those vaccines. And so I think people are perhaps reading back the kind of vaccine world back into the pre-vaccine world and thinking, it is unnecessary. But as you say, at the time, there's a real danger of health systems being overwhelmed.
And deaths, I mean, if you caught COVID-19, you had no vaccine, you had no treatment. And it was really devastating, particularly for the elderly and the vulnerable.
Absolutely. And just thinking about longer term future, I mean, you mentioned the influenza pandemic of 1918. That was, again, a kind of truly global pandemic. And so it's, how likely do you think we are to see, we like to see more pandemics in the future, more viruses that are going to have this, perhaps because of the more interconnected world that we live in, that make it around the world and are more devastating in the future?
Yeah, I should probably also put in the chat, if I could have a minute to look it up. Just had an article in JAMA on called The Age of Pandemics, and explains why we're likely to see more novel outbreaks in the future. There are a lot of reasons, ranging from very close animal-human interchange, deforestation and land management, climate change, the whole range of reasons. And it's been actually borne out in the last 5 years. We've had many more events of unusual outbreaks and zoonotic spillovers, and we're likely to have more in the future. So just like, we've seen, every year seems to be a new climate record, we might be seeing the same thing with pandemics or epidemics.
And thank you. Yeah. So there's a question that's come in from participants saying, thank you for a great talk. And in terms of thinking about the future ahead and possible future pandemics and preparedness, is the acceleration of the vaccine development process going to be a kind of vital tool in the toolkit to tackle future pandemics that we're likely to possibly see?
Yeah, I've actually just been having talks at the White House about that. I think we're really, all upper income, all countries actually, but particularly upper income countries, have really took their foot off the accelerator. I mean, basically, in my view, there are really only two things to do with the pandemic right now. All the other things are secondary. They're not that they're not important, in terms of, masking indoors when you're in a big crowded place. But the most important things are, one, vastly increasing vaccination rates, but including booster rates, because although you're right, Matt, these vaccines continue to be reasonably well effective against Omicron and variants and subvariants, and the new variants that are circulating. Nonetheless, they're not very effective at preventing transmissions, only against serious hospitalization. And the other problem is that their benefit for preventing hospitalizations and deaths wanes quite quickly within, say, 3 to 6 months. And so you have to keep having new boosters. And so the first thing we need to do is get more people boosted. The second thing we need to do is to have next generation vaccines. And we're really not investing. The US Congress put in a ton of money into Operation Warp Speed, to get the original mRNA vaccines out, which have been really fantastically successful. But now we're not putting any new money into next gen vaccines. I think the same thing would be true in the UK. You've got terrible problems there. and I just came back from Oxford, so I know.
Yeah.
And and my family's English. I come back all the time from the Lake District. So I think we really do. While the vaccines are still good, it would really be fantastic if we could invest in next generation vaccines. And I think what they need to do is be better at preventing infection, things like nasal vaccines. They also need to be more durable and not wane so quickly. And they need to be more targeted against subvariants. I mean, there was a big thumping of the chest by your and my government about the new bivalent vaccines. You got the worst end of the straw because you didn't even get, you got the original Omicron variant. We got, a lot of the more recent ones, but neither of our vaccines were particularly better than the original Wuhan strain vaccine. And so investing in the next gen vaccines, I think, would be a really smart move. And I just don't know why our governments are not doing it.
It feels to me like there was a bit of this complacency really from Western governments in particular, that they've had enough of the pandemic, that the vaccine seems to work pretty good. Let's almost just a head in the sand, and it comes to your point earlier as well about this north-south divide, that initially it seemed that there was a lot of self-interest from the north in particular to vaccinate the world, because it's in the interest of the world, right, of the north, that if strains are going to develop mutations, if that we're only going to be safe when everybody's vaccinated. And now, given that the vaccines seem to be okay against future strains, it seems like it's no longer the priority to get vaccine to kind of developing and southern world countries, which seems very short-sighted. And again, I guess it comes back to this lack of investment in other vaccines for the future.
Yeah, I think equity still remains really important, but it's actually quite even more complex than that now. There actually are enough vaccines to go around for the world, and there are excess vaccines. I know, in talking for the White House, we've offered vaccines to Africa, and they don't want it because they can't get uptake. They're having the same problems we are.
Right.
It says that their population doesn't want to take the vaccine either, and they're finished with they feel finished with. So they're not that different from us. We're all very similar. But I do think that in treatments like Paxlovid, we're not seeing the distribution as well, and we do need to invest in kind of vaccine delivery infrastructure in Africa. I think that's really important, and also vaccine information campaigns. The issue of getting all the world vaccinated with the right vaccines and to do it well is really a very big challenge, but it is the important one. You're right, Matt.
And just we've got another question here coming to the point about Africa, and it asks, where do you stand on the complex issue of why COVID seemed to have a lower incidence and impact in large parts of Africa compared to elsewhere, at least early on in the pandemic?
Yeah, I mean, I know all the theories, and I don't know, nobody, it's still called the African mystery. It just might be that it most likely, did sweep through Africa the same way it swept through us. There's no biological reason why it wouldn't, and I'm quite sure it did. So in terms of infection rate, it just simply might be under diagnosis and underreporting, which
Right.
is one very likely thing. Also, deaths and hospitalizations aren't as well reported, and the surveillance systems aren't as good. There might have been a lot of people dying at home that we don't know about. But beyond that, Africa has a much younger population than in most Western countries. They also have a more open outdoor lifestyle. And so I would say that probably a younger, healthier population is most likely the reason. So My best guess is Africa had as many infections as we did. It probably had more hospitalizations and deaths than it reported, but probably overall less than the hospitalizations and deaths that we experienced in the UK and the US, because they were a younger population. I think it's probably the most likely explanation for it, but nobody knows for sure.
Yeah, so perhaps not as mysterious as it seems on the surface when you take into account all those demographic factors. And as you say, got time for another question, I think, which is a more technical question about the kind of the law work in the WHO, and it asks, what is the clear distinction between the pandemic instrument and the IHR? What is it that had to be drawn up into a pandemic instrument that could not be included in a revised IHR? Is it simply the difference in the articles under which they fall?
Yeah, and that's a huge controversy and something that I'm right in the middle of right now. There are some people who think that we can do everything in the IHR, and we really probably should, because, the pandemic instrument, we don't know whether there will be one. We don't know how many people will sign it, and we don't know how robust the norms are going to be. Whereas we do know we have an IHR, we have 196 countries, and there are provisions in the IHR that really do go to equity. But I would say that the received wisdom in answer to that question is the IHR is mostly to do with global health security, preparedness, things like a robust core health system capacities for surveillance, laboratory response, and also for international assistance. But it falls short in terms of very precise mechanisms for equity and for other areas. But I've said on Twitter a zillion times, and I've said in Geneva a zillion times, that we really need to do as much as we can in the IHR as possible, and that we really do need to harmonize the pandemic instrument and the IHR, and we can't have them going on separate tracks. So far, they're pretty much going on separate tracks, I can tell you that. The IHR review committee hasn't met with the INB, although I've personally been in very close contact with the chair, Precious Matsutso, and others. So there's a lot of work to do, and first and foremost is to make sure that we have a harmonized global governance regimes.
Well, it sounds like you are doing what you can to help us get that. Help us get that globalized governance regime, which as we started at the beginning, thinking about the way in which COVID has been different, and it's really shone a light on the need for that global governance regime if we're going to have kind of global public health security and also equity at the same time of trying to prevent the sort of inequality that we've seen through the COVID-19 pandemic. I think we've pretty much reached the end of the time that we've got this afternoon. I appreciate you are jet setting all around the world with these committees and all this work that you're doing. So thank you for that. Did you have any final comments or priorities to share before we wrap this up?
No, just next time, let's do it in person in Bath. I love it.
Yeah, well, we'd really welcome that, and we're now doing events in person and hybrid, so we get the benefit of both the in-person discussion and also the online reach. So we're very grateful to you to be able to be with us online from the US today, and we would definitely like to take you up on that invite or that offer to come and speak at Bath at some time in person. So we'll be in touch about that, I'm sure.
Okay, sounds great.
Thank you very much. All that remains for me to say is thank you very much for your talk this evening. It's been fascinating to listen and to put these questions and discuss these things with you. I'll remind everybody that the recording of the lecture will be available shortly online alongside recordings of our other events and podcasts. And if you visit the IPR website, there'll be information on forthcoming events in the series with new events coming up in the new year. So I'll just say thank you again to Professor Gostin. Thank you for all of you joining us online. and I hope to see you at an IPR event, maybe the event with Professor Gostin in Bath at some point very soon in the future. So thank you for joining us, and good night.